Hello, everyone. My name is Katie Varghese, and I'm very excited to teach this lecture. I also am looking forward to meeting you all in a couple weeks for the discussion portion of this course. Now, before we jump in, I just wanted to take a moment to introduce myself. I live in the fabulous Las Vegas, Nevada, with my husband, Jason, and I've been an occupational therapist now for about 4.5 years, primarily in the inpatient rehab setting. I am also excited to graduate this May with my post-professional doctorate from Creighton University. I also am very passionate about neurorehabilitation and addressing mental health in non-traditional mental health settings. Aside from work, I really enjoy hiking. We just completed Havasupai this last fall, which was absolutely unbelievable. Highly recommend doing that hike at one point in your lifetime. And I also am heavily involved in my church. This includes leading a teen recovery program every week with my husband. I love the program because it provides me an opportunity to really use my mental health skills from an occupational therapy lens with these students. So as I mentioned before, I'm very passionate about mental health, which has primarily been influenced by my own mental health challenges. I have struggled with both anxiety and OCD since college. And it has been through my own mental health journey that I learned the power of evidence-based practice for recovery and well-being. It has also helped me develop immense empathy for others who struggle with their own mental health challenges. It is honestly a huge reason why I went into occupational therapy school, and it's a big reason why I strongly value holistic care. I truly believe that the only way to actually heal and connect to a person is through addressing all aspects of their wellness, mind, body, and spirit. All right, so now we're just going to review the core objectives. So by the end of this lecture and discussion portion of this course, you as the student will be able to meet these core objectives. Most of these are in relation to being able to understand the impact mental health has on our patient's physical recovery, what we can do as therapists to address our clients' mental health needs, and also to be able to reflect on your current caseload and apply some of these strategies. Okay, so to start off our lecture, I think it's really important to go over some of these statistics just to highlight the gravity of mental illness in our own society. So 1 in 5 adults struggle with some type of mental illness, with 1 in 20 who struggle with a serious mental illness. A serious mental illness is defined as a mental or behavioral disorder that significantly impacts functional participation in at least one major area of their life. So, for example, someone with major depressive disorder may be unable to leave their house and go to work. I would classify that as a serious mental illness because it's impacting their occupational participation in work. When looking at children ages 6 to 17, the prevalence is 1 in 6. It's important to note, though, within this age group, one study found that close to 50% of adolescents suffer from some sort of mental health disorder. So you can see that there is a very high prevalence just within the teenage population. By just these statistics alone, you can see how prevalent it is in our society. It also shows how common we probably come across individuals with comorbid mental health disorders in our practice. So this slide outlines additional statistics to be aware of. So women have a higher prevalence than men of experience a mental health disorder. I'm not sure how accurate this difference is, primarily because women are also more likely to seek treatment, which is how they essentially diagnose if someone has a mental disorder or not. However, I think there has been a movement and emphasis on men's mental health in the past couple of years, which is great, right? We want more awareness and want more people seeking treatment. So I'm curious if we will see a change in the statistics in the upcoming future of more men seeking treatment. Therefore, that number might actually be skewed. It's also very important to point out that the incidence of mental illness is higher in individuals who identify as LGBTQ+, which is dependent on a number of factors, including experiencing a lack of support in their home and also the amount of discrimination that they face on a daily basis. So as therapists, it is vital to be aware of vulnerable populations and those most at risk for mental health disorders to ensure we are addressing the psychosocial health of our clients and also screening them for symptoms and risk factors within each of our sessions. So this is the current breakdown of mental health illnesses based upon their mental health condition. As you can see, anxiety-related disorders are the highest, with major depressive disorder following. With this, though, I think it's really important to point out that even if someone does not meet the diagnostic criteria for a mental health disorder, people can still be experiencing symptoms that are negatively impacting their life and recovery. Also, a huge challenge with these diagnoses is to meet the criteria, an individual has to be experiencing symptoms for X amount of months. So for example, with generalized anxiety disorder, the diagnostic criteria is experiencing symptoms for at least 6 months. When we think of our patients, especially in the hospital setting where I work at, they have just received a new physical diagnosis or sustained a new injury. Because their mental health symptoms developed recently, they technically may not meet the diagnostic criteria for a mental health disorder in relation to time. However, if those symptoms go untreated, they can develop into a full-blown anxiety disorder. For example, in one study that analyzed predictors of post-stroke depression, the researchers highlighted that many of the risk factors and predictors of post-stroke depression are similar to those for developing major depressive disorder. So this is highlighting how post-stroke depression can be an acute onset of the development of major depressive disorder. So this further shows the importance of addressing our clients' mental health symptoms, regardless if they have a diagnosis or not. It is also very important to highlight how physical disabilities can significantly impact one's mental health. So this is not an exhaustive list by any means, but these are some statistics to demonstrate how vulnerable individuals with disabilities are to experiencing or suffering from a mental illness. This also further displays our role as therapists to screen regularly for comorbid mental health illnesses. We have this unique opportunity, and I would also say privilege, to walk alongside our clients during very vulnerable moments and times of their lives. This opportunity opens the door for us to be an influential part not only of their physical recovery, but their mental recovery as well. I know this slide has a lot of statistics, so if you need to take a moment and pause this video to review them, you are more than welcome to. So now let's talk about how mental health impacts our physical recovery. So research has found that mental illness puts you at an increased risk for development of cardiovascular disease, primarily due to the prolonged physiological effects stress puts on the body, including increased cortisol levels, cardiac reactivity, and increased calcium buildup. It is also important to consider how mental illness can impact one's lifestyle, such as with poor nutrition and impaired sleep. There's also a lot of research that shows a correlation between substance abuse and mental illness, and also sedentary activity. So when we think of all these contributing factors, they can lead to the development of mental illness. I also really love this figure that was created by the CDC because it displays the mind-heart-body connection that shows how our behavioral and physiological pathways influence one another. So when we are addressing clients' mental health, we are also supporting their physical health because it's all interconnected. And so secondly, mental illness increases your risk for hospital readmission. One study I found suggested that 37.5% 5% of individuals who were discharged from the hospital with a mental illness were readmitted in the same year. The conditions that had the highest prevalence of hospital readmission included alcohol and drug dependency, dementia, individuals with psychotic disorders, autism, impulse control disorders, and also personality disorders. When looking at the stroke population specifically, being diagnosed with more than one mental health condition was significantly correlated to hospital readmission and also early death, with depression being the highest condition that's associated with hospital readmission within 6 months post-stroke. There's also a link between decreased life expectancy with mental illness. So depression has been linked to a 50% increase in a person's risk of dying with cancer, and also a 67% increase from heart disease. So you can see how it really impacts physical recovery when you have some sort of mental health challenge along with a physical condition. And probably the most influential consequence of mental illness in relation to our profession is how it negatively impacts ADL performance and functional progress. So, for example, one study I analyzed found that individuals who sustained a hip fracture, up to 52% displayed a fear of falling 1 to 3 months post-fall, which was correlated with poor functional recovery when they analyzed it from an ADL standpoint. So this just further demonstrates the impact mental health has on the rehabilitation progress and process. But the cool part is, this is where we actually can come in. So we can address mental health to either reverse or prevent these negative outcomes from happening. And I think that is just so cool that we have that ability, because just as our physical and mental health can be negatively tied together, it also just as easily can be turned into positive well-being, which is the beautiful part of our neural restructuring that we have. Due to that interconnectedness, mental health can positively impact our physical health through reducing one's risk for cardiovascular disease and promoting healthier lifestyle habits, including medication adherence, getting regular checkups from the hospital, and participating in physical activity. Also, one of the most incredible things is positive well-being can improve one's recovery from physical illness. One meta-analysis I found analyzed the impact of emotional well-being in individuals with physical illnesses, including cancer, diabetes, stroke, spinal cord injury, and orthopedic injuries. What they found was higher levels of emotional well-being were beneficial for recovery and survival rates in these patients that had a physical condition. It's also important to consider some of the past studies I talked about in relation to stroke and how the absence of mental illness showed to be a very positive contributing factor to the recovery as well. I just think this is so cool that we can actually use our patients' mental health as a strength, a protective factor, and a facilitator to their physical health and recovery. So now we're going to go over the barriers of addressing mental health in our practice. So I believe most healthcare workers believe mental health is important to address. However, it is not always translated into practice. When I was completing a literature review for one of my projects in school, these were the barriers I found that clinicians reported impacted their ability to address mental health with their patients post-stroke. I know this article was specifically assessing OT perceptions and barriers from addressing mental health with stroke survivors, but I believe this can be applicable across multiple settings, conditions, and disciplines. I think for me personally, the biggest challenge I have faced with addressing mental health in my practice was a lack of confidence in my ability to address these issues. And also the expectation to ensure my patients were progressing physically. Since I work in an acute rehab setting, I have a really limited amount of time with each patient, which adds pressure to ensure each day they are progressing closer to their goals. What I found, though, was if I didn't address their mental health, it significantly impeded their function to where they were not getting better both physically and mentally. So what I did was I started to formulate creative ways to ensure I can address mental health while also promoting their physical recovery as well. This is also super helpful for billing purposes if that is something that you are also worried about in relation to documentation and being able to articulate why you're doing an activity to also promote physical function. So some examples that I have done with my own setting include leading a meditation while also focusing on pain management. I've had patients complete multiple different mental health interventions in standing, such as the Kawa model, which also can address balance and standing endurance. And I also have my patients work a lot on fine motor skills or coordination by having them create something such as a gratitude jar, or if we're working on handwriting post-stroke, having them journal is also a great way to incorporate mental health components while also addressing their physical recovery. All right, so I wanted to transition to talking about the clinical presentation of common mental health disorders we see in our practice setting. So we sometimes are very aware of our clients' mental health challenges if they have a diagnosable condition in their medical chart. However, at least in my own practice, there are many people I come in contact with that display these symptoms without a formal diagnosis. So that is why it is important we are educated on the signs and symptoms of these conditions to ensure we are implementing the right interventions and or referring them to disciplines that can support their psychosocial health. So the first condition we are going to talk about is depression, specifically in adults. So how I organized this slide is on the left, I outlined the diagnostic criteria for major depressive disorder, while on the right, I attempted to highlight what that might look like in therapy or how they may present when we're interacting with them in sessions, just to make it easier for us to be able to detect what that looks like in everyday practice. So when looking at these symptoms, some of them are a lot more obvious, right? Depressed mood, sleep difficulties can be very common signs of depression. Or we sometimes have conversations with our patients and they might communicate to us that they're feeling lonely or hopeless or even depressed. So those are a lot easier ways to detect if our client is experiencing depression. However, there are some that are just not as obvious. So for example, low motivation. This can be challenging because we probably have a lot of clients that might have low motivation, but it's not necessarily due to their mental health, right? It could just be a personality characteristic. But how I like to think about it is you want to see a change in their status, especially with low motivation. So you might have been working with a client who was initially really excited, motivated, participating. And then as the sessions continued, you started to notice that they're having a lack of motivation or a lack of drive to participate. That can be a sign of depression. And what I would suggest in those instances is to try to sit down with them and ask questions about how they're feeling, about how they think their progress is going, what's going on at home. Is something impacting their participation in therapy? And see if that is a great gateway to learn more if they might be struggling with some sort of mental health challenge. Another fun one is those agitated and irritable patients, right? So I think this also is related to seeing a change in their personality per se. So we do sometimes have those patients or clients that might just be more irritable or agitated at baseline, but it's oftentimes a change that I notice where they become more agitated. It's not how they usually present. That allows me to think that they might be struggling with some sort of mental health challenge. For example, I once had a client who was very pleasant and motivated, and he was making really great gains in my perspective. And then one day, out of the blue, he just got very agitated and irritable. It just felt like everything I did or I said just caused him to get more frustrated, like I couldn't do anything right. And that really had me think that there was something else going on underlying, because that's just not how he usually presented in our sessions. And so I sat down with him and I really tried to get the nitty-gritty of what was happening. He then shared with me that he was getting really frustrated with how he was doing. He felt very hopeless. He also just was worried that he wasn't going to be able to get to a place to go home. And so that agitation was a projection, right? A lot of times, anger is a projection for some sort of underlying emotion. And what he was really feeling was sadness and fear. And it was just showing through that agitation. So sometimes you have to kind of tease through some of those secondary emotions like agitation or anger to get to the root of what's going on. Another one is limited interest in participating in therapeutic tasks, or just kind of a decreased interest, especially in something they once found meaningful. So you might have a patient that comes to you and has started to share that they stopped participating in activities they loved, like swimming or gardening or social participation. That's usually a big key sign of depression. So furthermore, that can cause them to also miss appointments. So I think of our individuals that work in an outpatient setting. This could be something that you would see because when you think of someone that has severe mental health illness or depression, it might be really challenging for them to just get out of bed, let alone to leave the house and go to a different facility and have to socially interact with people. And so frequently missing appointments, especially if that's not their norm, might be another common symptom related to depression. Or if you work in a facility like me, where your patients don't leave, it could be that they're frequently declining services and really just have that lack of motivation or drive to get out of bed and do something. I think something I more commonly see in my setting that is not frequently talked about is how depression can really impact an individual's cognition, especially with attending to tasks, their memory, and decision making. So you might notice in your clinic that you're having to repeat to your client things over and over again that you have already talked about, and you know that they don't have an underlying cognitive condition or deficit. Or maybe they're having a really difficult time adhering to their home exercise program. So these are also subtle signs that it could be related to a mental health issue versus a cognitive issue. Okay, so now we're going to transition to talking about anxiety in adults. This slide is structured the same as the last one, with the diagnostic criteria from the DSM on the left and how that might present in your therapy sessions with them on the right. So I know we touched already on cognition, but anxiety can really impact executive functioning with being able to concentrate. I can remember this patient I once had where we were transferring onto the toilet and she was just so anxious and so afraid that she was going to fall that she stood up and then she started to have a panic attack and start yelling, "There's nothing I can hold on to. There's nothing I can hold on to." And the grab bar was literally directly in front of her. And so what I had to do was calmly take her hand and place it on the bar and tell her, "Here's the grab bar. Let's take a deep breath, then pivot towards the toilet and sit down." But I think that's a good example to show you that when you are in that heightened fight or flight response stage, you almost have tunnel vision. Like you're not able to see the forest through the trees, and it makes it really hard to plan. It makes it really hard to problem solve. And so they might need extra support with cueing if they're having a really hard time processing or sequencing a task due to their anxiety. It's also common when they are anxious that they may be resistant and fearful when attempting new or challenging things. A huge part of anxiety is avoidance. So they're going to try to avoid things that might elicit that anxiety symptom or the fear that they're experiencing. And they're fearful of something very unpleasant from happening, right? So there's this avoidance. So when you start to get them to do more challenging activities, you might experience a lot of resistance and fear, and that is probably due to the anxiety, especially if you already know as the clinician that they are ready to take that next just right challenge. They might also just need extra encouragement and support to understand their own abilities in those moments. Increased heart rate and respiratory rate. And so as you can see, anxiety can really impact your physiological functioning. So you may see their heart rate or respiratory rate increase. However, there's not really an underlying cause medically that's impacting their cardiovascular system. Impaired insight into abilities and functional performance. This is probably one of the most common things I see with my clients with an anxiety disorder. And it's interesting because I think we oftentimes have clients with cognitive deficits that believe that they can do a lot more than they can, right? So they're the ones that are impulsive, trying to get up by themselves, trying to do all these activities alone when they're physically not ready yet to do them. My clients with anxiety are almost the opposite. We have these individuals that have the physical capability to do things, but mentally they don't believe that they are able to do those tasks. So they're oftentimes very fearful about discharging home. They're very fearful on attempting things more independently, just because they truly believe that they are not ready, and it's primarily due to that anxiety. My grandfather actually sustained a stroke a couple months ago. He has recovered well physically, but currently is experiencing a lot of anxiety. He is very fearful of falling, so he sometimes will continue to use his walker, even though the PT has recommended discontinuing it. It has been interesting to use some exposure strategies with him when he would push the walker in front of him and then take a few steps unsupported, to me trying to expose him and progress him to walking outside together with me pushing the walker so he had it nearby just in case, to him walking completely alone without me or his device. So you can kind of see how I tried to use some of those strategies also with my grandfather to help him overcome his own anxiety after his stroke. Other individuals complain of muscle pain, which is not due to an underlying musculoskeletal cause. Some common areas of the body and anxiety muscle tension arises is in the neck, upper shoulders, or the jaw. This is also not listed here, but another common one I see in my practice is GI-related issues to anxiety. We can all think of those clients who are excessive planners and questioners, and a lot of that has to just do with feeling like they want to be in control. So anxiety makes you feel out of control, and so they will try to negate those feelings by trying to be in control of everything within their environment. And so this is a very common one. So if you start to have patients that you feel like they want to be in control of the session and kind of every single thing that you're doing within it, they try to think about that from a psychosocial lens next time. What it really could be is that their anxiety is causing them to be very fearful of releasing the reins to you as the clinician. And that's when collaboration and therapeutic use of self is so vital, because you can really work on building that trust and also allowing the client to feel in control, but trusting you enough that you can provide suggestions to help improve the rehabilitation process. Okay, so we are now going to transition to talking about the clinical presentation of mental illness in children. I have a couple of disclaimers with this. So first, when I'm going through this clinical presentation, I want you all to know I'm not specifically addressing autism. So autism is classified as a mental health disorder in the DSM, but for the purposes of this presentation, due to the uniqueness of autism, these are symptoms that are primarily related to anxiety, depression, and ADHD. Because, as the research shows, children with autism can also have these comorbid mental illnesses. Second, I did one of my fieldwork rotations at a pediatric clinic, specifically a mental health clinic for children who've experienced trauma. And so a lot of this I saw on an everyday basis, but I'm also not an expert in pediatrics. It's not where I have most of my clinical expertise in. So I really look forward to our discussion portion to learn from you who are working in the pediatric setting about common clinical presentation and also strategies you use with your kiddos. But that being said, some of the common symptoms include frequent tantrums and constant irritability. So these could be your kiddos that just have a really hard time regulating throughout the session. And I remember the challenge I had at that mental health clinic was oftentimes I felt like the majority of my session was really focused on just getting them to a place where they can emotionally regulate so they can participate in something functional. So you might have kids that are just really having a hard time being able to emotionally regulate, and that could be a sign of mental illness. Also, children may complain of stomach or head pain without an underlying medical cause. So we as adults can communicate when we're feeling anxious or depressed. We can understand what's happening on a physiological level related to our mental health, but children don't necessarily have that insight. That is still developing. And so they might be experiencing these physiological sensations of anxiety, but it's coming across like they have something medically happening, like stomach pain or head pain. So that will be something to consider when you're working with kiddos if they start to complain a lot about having these types of physiological symptoms. It could be anxiety related versus medically related. And at that point, I would recommend to their guardian to visit their pediatrician. A lot of children with mental illness struggle with sleep irregularities, similar to adults, but oftentimes this includes a lot more nightmares or night terrors. They could be sharing their fears or worries very excessively. So that's actually something that's very common for children who eventually develop OCD, is that at a very early age, they're talking about their fears and their worries pretty constantly with their parents or people that they trust. They might start to isolate from family or friends so that could be related to depression, where they start to socially isolate from their loved ones because of their mental health. And if your kiddos are older, like such as if you're working with adolescents, they might start to engage in riskier behaviors, such as experiencing with substances. And this could also impact their social and academic participation on many different levels. So you just want to be aware of how mental illness can really impact not just one area of their life, but also all their areas as well, just as we see that in adults. Okay, so now that we have this clinical idea of what an individual or child presents like when struggling with comorbid mental illness, I want to dive into analysis and treatment. A great model that can be helpful with gaining further understanding of how psychosocial health can be impacting physical recovery is the biopsychosocial model. I also love this model because it challenges us to look at our clients holistically to understand how different factors of their wellness and health impact one another. I also collaborated with one of my PT colleagues who told me this is a common model used in physical therapy practice. So I hope this is applicable to all of you that are in your PT residency. So this model emphasizes that there is a dynamic relationship between our biological, physiological, and social dimensions that impact our personal health. Within each context, you have facilitators and barriers that influence functional outcomes and performance. So mental health can either be a strength or a weakness in relation to our clients' overall goals and health outcomes. The incredible thing, though, is we have that ability as the therapist to influence recovery and what that model terms areas of impact. So we can provide targeted interventions and evaluations within these different dimensions to positively influence functional recovery. So this specific figure that's highlighted from a sports medicine frame of reference describes how each dimension can influence not only our biopsychosocial outcomes, but our rehabilitation outcomes as well. This figure is very similar to the previous one. However, Gentry and his fellow researchers modified the original figure to fit within an occupational therapy frame of reference. So I encourage you all to pause this video to take a look at both of these figures to gain further knowledge on how these components influence our OT and PT outcomes. All right. So I think it's also important to highlight the trauma-informed care model when discussing mental health. So this model is applicable to every single therapist because you can come across an individual or a child who have experienced trauma in pretty much every setting. This was actually the primary model that I used during my fieldwork rotation that I discussed earlier at that pediatric clinic, who specifically addressed children who have experienced trauma. This model recognizes the impact trauma can have on an individual's health, their access to services, and also their motivation to engage in supportive services. It also emphasizes asking yourself not what is wrong with the person, but rather what has happened to the person. This encompasses taking into account how much trauma impacts behavior, And through this model, we can create a safe space, allowing our clients to feel in control and foster trust through that therapeutic relationship, and ultimately empower our clients to build resiliency. Please check out the resource that I provided at the bottom of this section of the PowerPoint, because it's a great article that highlights how you can address and utilize trauma-informed care in pretty much every setting that most of us work at. Okay, so I know this is not really classified as a model, and there are many other theories for how individuals process grief. This is just the most well-known theory, so I included this here so we can discuss grief. Grief can occur in many stages of one's recovery process. It does not just occur in our clients who are dying. It can be related to coping with the loss of independence or mourning the person that they were prior to the condition. I also think of parents who might be coping with their child's condition. How might they be grieving the aspirations they had for their child prior to learning of their condition, or if they sustained a traumatic injury? We have the privilege to walk alongside our clients in this grief. It is important to allow them space to experience all these emotions, because ultimately it can lead to acceptance. Sometimes it requires grieving the person they once were to making room to accept and enjoy the person that they are now. I think of my sweet grandfather, who I said had a stroke. He has been struggling a lot with his change of independence, especially with driving. I would say when the subject comes up, he fluctuates between anger and depression. I have tried to create a safe space for him to express those emotions. He is in the process of grieving who he was before the stroke. As an OT, I have tried to come up with many suggestions to preserve his independence. However, for right now, I think the best thing me and my family can do is sit with him in this grief. My hope is through time, he will adjust to this new routine and find fulfillment in his new perceived independence. I included this slide to encourage you all to make space for your clients to grieve. I am guilty of this, but I think sometimes we as therapists are so solution focused. We have to create a space for them to just experience their feelings, so they are at a place to hear all your fantastic ideas. So outside of models, there are also quite a few assessments we can use to quickly assess our patient's mental health. This is not an exhaustive list, but a few that often come up in the literature that are easy to administer are listed here. Although we cannot diagnose a mental illness, we can communicate to the medical team when we are seeing signs and symptoms of these conditions. With this, though, it is important to always, I can't stress that enough, assess mental health, even informally, with our patients. Think about how you start every single session, usually with asking the question, how are you doing? So even by asking that question, you're not just looking into how they're physically functioning, but their emotional well-being as well. I also cannot stress this enough, that you cannot treat a patient physically if you have not helped your patient overcome the mental health barriers that are impeding their function. That is why addressing mental health is so vital in our practice. Okay, so now we are going to move on to the fun part of our job, and hopefully the fun part of this presentation, which is talking about mental health interventions we can use in our practice setting. We're going to first start with talking about mental health interventions for the adult population. So the most important thing to start off with is psychoeducation. It's really important that we are constantly educating our clients, not only on how their condition or injury might be impacting their physical health or their physical recovery, but also their mental health. This is really important, especially for my setting, because they might not necessarily be experiencing mental health challenges now in the hospital, but they could when they go home, especially for chronic conditions or conditions that might take a lot longer to recover from, such as a stroke. That was something that the research talked about, that individuals who had discharged from the hospital were saying that they didn't feel adequately prepared to address their mental health after leaving the hospital. So we really want to be educating them on that. I also think this is a great way that you can collaborate with your client to really understand the coping mechanisms that they already have used previously that helped with their mental health. So if they shared how meditation or mindfulness or any of these activities were really beneficial to them, you can start to incorporate those within your session, since it's already a tool that they have and that they frequently use. So it makes it a lot easier to really dive into addressing their mental health if you already know their established coping mechanisms. So the Kawa model activity is actually something I love to use with my clients. And I know the Kawa model is really big in the OT world, but for our physical therapy friends, the Kawa model is basically using a river as a metaphor to our life. So it usually is done through a craft or drawing, or you could even probably do it through open dialogue. But through this activity, you start to acknowledge the things that are supporting you or hindering you that maybe are barriers to your recovery, both physically and mentally. And this is a really, really great way to just get the conversation started of how they are feeling and what is really impacting their physical function and their mental health recovery as well. And I really like this activity because it's easy to implement while also incorporating something physically related. So either you can have them doing fine motor tasks through coloring or writing, or as I've said before, I frequently have my patients do this in standing. So it really works on standing endurance and tolerance while they're doing this task. There's also colleagues that I have that do the Kawa model in a group setting. And I think that is a fantastic way to really get clients to be able to talk amongst themselves, especially with individuals that are going through maybe a similar condition or situation, because it just provides them a lot of support, insight, and wisdom, and just empathy to know that they're not alone in what they're going through. Motivational interviewing is another great intervention that can be used in many different settings because it's focused on eliciting behavioral change. Us as therapists structure the way that we ask questions to have the clients draw out their own conclusions and meaning so that they can elicit the change they want. I think of you in acute care who may not have the ability to complete a full mental health intervention due to lack of time or resources. This is a great one that does not require extra materials, and you can do it just as you're evaluating them, which is great. Meditation and mindfulness strategies. So this is another great one that I think can be easily applied to many different settings, and it oftentimes can be done in a very short amount of time, especially mindfulness strategies. So something that I often use with my patients is the 5 senses approach. So what you have your patients do is that they need to tell you 5 things that they can see in their environment, 4 things that they can touch, 3 things that they can hear, 2 things that they can smell, and 1 thing that they can taste. And it really tries to draw their focus away from what's going on in their head to really focus on the present moment or the present environment. And I would also take it a step further to really encourage your patients to engage in something that they really love doing. So we're then incorporating that meaning and occupation based within that. So maybe it's that they love shopping or playing card games. So that's another way you can incorporate exercise while incorporating something occupation-based that they might enjoy doing that promotes their physical and mental health. Whenever I have a shopper as a client, I set up a mock store in our gym to help elicit practicing their favorite task. By promoting their autonomy and the activities that they love, we're also promoting their mental health. Breathing techniques. So this is another very common one I use quite frequently in my practice, especially on the spot. This can be really helpful when we're just trying to regulate their respiratory rate and to calm their nervous system so they can participate in the task at hand. Cognitive behavioral therapy. So cognitive behavioral therapy is another really promising intervention which focuses on rewiring the brain by challenging our thoughts and behaviors that are dysfunctional in order to establish more adaptive coping skills and thought processes. The thing with cognitive behavioral therapy, though, is it's not a quick fix, right? And when you really think about rewiring the brain, that is going to take a while. And it usually requires mass amounts of repetition in order to elicit that type of change. So this is something that you can oftentimes recommend as homework. So maybe you talk about it in your session, but you also provide it as homework, such as with journaling or providing cognitive behavioral worksheets that they can find online. There's a ton of resources out there, but that gives them the ability to practice cognitive behavioral therapy on their own. And when looking at this research, there's a ton of research that supports the efficacy with cognitive behavioral therapy with a variety of populations, including anxiety, depression, spinal cord injury, and cancer. I included that link in the bottom of these notes so you can take a look at that article if you're interested. The next one is spirituality. So this is something that I oftentimes use with my clients in the hospital setting. I focus on drawing on what is meaningful and what they find purposeful in their life. And how are we able to use their faith and the things that they find meaningful to be able to really elicit change within their own mental health? I have found that spirituality is often how my clients cope with their conditions while in the hospital, and they appreciate it when I incorporate it into their sessions. So, some examples I have used with my patients is I've had them walk while praying the rosary. You can see how that also promotes dual task training. I also frequently have my clients create crafts that focus on positive affirmations, gratitude, or even including scripture verses. Mental health referrals. So this is really essential, and it's really important that we refer when necessary. So especially once they leave the hospital, it's important that we are providing them the resources and information of who they can contact. So that could either be a psychologist, a psychiatrist, or even a licensed counselor. There's many different referral routes you can go to, and I oftentimes just provide all of them so that they can make the best decision for themselves and their family. And also support groups can be a great way that they can come together and just discuss what they're going through and problem solve together on ways they can improve their function. I lead our stroke support group here at my hospital, and many of our clients have shared their favorite part about group is the social support and to learn that they're just not alone in their experience. All right, so now we are going to transition to talking about mental health interventions for children. And when I was looking at a lot of the literature on mental health interventions for children, many of them talked about this community health model that's related to public health. And it's oftentimes implemented in school settings, and it's organized into 3 tiers. So the first tier focuses on school-wide level promotion and prevention. So how are we really educating our children and preparing them to know how to emotionally regulate themselves to prevent the development of mental health disorders in the future? And then the second tier focuses on students most at risk for mental health or behavioral problems. So still focusing on that prevention piece. And then tier 3 would be the highest level, focusing on intensive services. So those are children that have a diagnosable mental health disorder. So within the school setting, they talk about all of these different tiers from a public health model that can be helpful to show how we should be addressing mental health regardless of if a child has a mental health disorder or not, because it's also a really great way to prevent the development of a condition later. Furthermore, these are just some of the interventions that I found within my literature. Like I said, I'm very excited to hear from our pediatric specialists on the interventions that they use with their clients, because I just haven't had a ton of clinical experience in a while working with children. But first, cognitive behavioral also has been shown to be effective in children. Sensory integration therapy is something that we constantly used within my practice at that mental health clinic. So just really using different types of strategies to calm the body, calm that nervous system so that they're able to participate in the task. And I think it's really important to highlight here that with children, we really need to address the behavior first before we're able to get the child to do anything desired that we want to focus on in therapy. So if they're not in a regulated state, they're not going to be in the right ability to learn, to be able to grow, to be able to even attend to a task. I think of this child I once had that would get so dysregulated throughout session that she just could never attend to any sort of table talk activity. And at the beginning of our sessions, I really had to focus on just implementing emotional regulation tools. So we were doing a ton of singing, incorporating proprioceptive and vestibular input to just try to really calm the environment down because she would just get so overwhelmed. And then we were able to slowly start to implement tabletop activity. So then it was like she was able to attend for a minute and then she would dysregulate. And then we implemented those regulation tools. And then she was able to attend for longer and longer. And you can see how we really had to address her mental health to be able to really address anything that was related to her functional performance. Other interventions include parent education. I think this is huge. So if you're noticing that there's really a strategy or tool that works well in your session, to let the parents know and educate them on how they can carry it over at home. I think it's really important. So we're not just promoting their mental health in our session, but having it carry over to their home and school environment. Creating and designing a safe space. So I've heard parents state that they have an area in their kids' room that has some of their favorite toys, some calming things that they can engage in if they're becoming overwhelmed. So they have that designated space to go to. There's also a ton of social emotional learning programs that are in school-based settings, which I'm not super familiar on. So I'm really excited, like I said, to hear more about that if we have any of our PEDS specialists out there that work in schools. Lastly, there is a lot of self-regulation programs out there. I think the most common one I remember is How Does Your Engine Run? But this includes programs that we can implement to just help them with their self-regulation so that they're able to find enjoyment in the session and also communicate their needs. This also can promote participation and just promote their over psychosocial well-being. I think that's oftentimes why they use a lot of these in the school to really teach kids how to understand their own emotions and understand where they are from a self-regulation standpoint so that they can attend to tasks. Okay, so now we are going to focus on mental health interventions for adults with severe cognitive deficits. So I think what's really important here is we need to switch our approach when we are working with adults with cognitive deficits. A lot of this research is specifically related to dementia and other neurodegenerative diseases, but I also believe it can be applicable to other conditions that cause lasting cognitive deficits. So how are we able to promote their mental health despite the challenges of their cognition? So oftentimes when there's a cognitive deficit involved, they really need the help of a loved one or a caregiver or even us as their therapist to help regulate their emotions. So we have this ability to turn inward and to determine how we're feeling and what it is that we need in order to feel better. And that can be lost or diminished when there's a cognitive deficit involved. So it requires us as the therapist and caregivers to be able to create and modify the environment to make it conducive for the individual to regulate their emotions and also promote their psychosocial health. So a big way we do this is through sensory modalities. So there's different types of stimulation that we can do to modify the environment and promote therapeutic participation. So with our individuals that might be more depressed and we want to improve their alertness and get them more motivated and ready to participate, that might be including more movement or exercise in our therapy. So more alerting stimuli. Also, heavy work is a great one, engaging them in something like mopping the floor or helping with laundry. Engaging them in some sort of task that requires a little bit of lifting can be very alerting for them. Also, light touch is a stimulation that's oftentimes very alerting. So we're trying to get them to a place where they can be aroused to be able to engage and participate. On the flip side, some types of stimuli we can use for calming strategies when they're feeling overwhelmed is deep pressure. So adding proprioception into your treatment, calming music, calming voices, dimming the lights. So you're creating a calming environment and kind of decreasing all this extraneous stimuli. And also getting them maybe isolated away from people so they can just take a moment to really calm that nervous system. The research also discusses creating a sensory plan, and I included the link in here that it's really interesting article of just talking about how we can utilize this plan to analyze and understand an individual with a cognitive deficit's daily routine. So to incorporate this into your sessions, you first want to determine the activities that you really want them to engage in and want them to have the highest level of alertness for. And so what this talks about is basically planning the day to incorporate both waking times and decreasing stimulation time so that they are at their optimal level of alertness for when we want them to engage in that purposeful, meaningful task, such as bathing, or maybe they're having a family function. So you want them the most alert to be able to engage with their loved ones. So the waking time is when we're really focusing on getting their level of alertness ready for an activity. And then they're at their most alert state when we want them to engage in that task. So then immediately after that task engagement, you want to incorporate ways to decrease that stimulation, helping them calm and regulate their nervous system so that they don't get overwhelmed. So then they can go through the process a few times throughout the day. As you can see in this graph, they kind of do it in waves. So that is how you would create a sensory plan. And I like to collaborate with caregivers on this plan to help them learn how to optimize their loved one's participation in daily activities. Another one is designing a fidget blanket. So in the bottom right, that is an example of a fidget blanket that I created with a caregiver for their loved one with severe dementia. So this is just another great sensory way to provide our adults with cognitive deficits to just help with emotional regulation. And what I love about it is you can really tailor it to the individual. So I remember this caregiver added a lot of stuff related to cats because her mom loved cats. She also grew up on a peacock farm, so that's why she wanted to include some peacock feathers there. And you can also include activities that they can do, such as with buttons or ribbons or things that they can touch and manipulate. So it just gives them something to do, or I guess the word fidget with, right? If they're feeling a little bit more agitated or restless. Exercise is a great one. We talk a lot about exercise in general, but that's something that can be an effective strategy with cognitive deficits. And like I said, always trying to engage it in something that's meaningful and something that they can connect with. So maybe it's going on a walk with their grandchild. We also want to adapt meaningful tasks and activities based upon their cognitive level as well. That's another effective strategy. Mary Platt is another resource at the bottom I included, but she talks all about the Allen cognitive levels and how you can modify each activity so that they can continue to engage in that task as independently as possible. But it's all about creating the just right challenge. So that's a great way to also educate caregivers because we really want them to optimize their engagement throughout their lifetime, right? Even if they have a cognitive deficit. So how are we promoting autonomy and independence despite their cognitive deficits? Music therapy is another good one that has a lot of research behind it. It always makes me think of that movie Coco and the power music can have with promoting quality of life in dementia. I highly recommend that movie if you haven't seen it. There's also some new and upcoming research about the use of robotic therapy animals. They respond to touch and sound, so they simulate a real pet, but it obviously takes out all of the unpredictability of a real animal. So they're designed to provide comfort and support to individuals with dementia. So that's another kind of up and coming thing that's within the research for helping individuals with dementia emotionally regulate. And the next one is social participation. So we talk a lot about that with dementia, but it can cause them to really socially isolate from their family and friends. So we really want to promote that. And lastly, it's always important to think about the caregiver, right? Make sure that we are addressing the caregiver's mental health as well, as they're kind of taking on this role of providing service and support to their loved one. Okay, so now we are going to move on to talking about a case study I had in my own practice setting. So I once had a patient who was in the hospital because she sustained a hip fracture from falling. So because she experienced that trauma of falling, she was very fearful of falling again. And her fall occurred in the bathroom of her home. So because of this fear, she had immense anxiety of transferring on the toilet. So much so that she preferred to use a bedpan, even though she, I think, was walking like 100 feet, contact guard assist. So you can really see how, from a functional standpoint, how much her anxiety was impacting her physical function and progress. So early on, I realized that if I did not address her anxiety, I would never get her to progress physically to reach her goals, which her goals were to go home alone independently. So that meant that she would need to be able to complete all of her ADLs and IADLs independently, including toilet transfers. And she also had a very huge social life because she loved crafting. So she was in all these craft clubs. So she wanted to be able to get home to be able to re-engage in those activities. So some strategies I used included exposure therapy. So first, I just had her practice transferring onto the commode from the bed. I then had her just go into the bathroom, not actually transfer, but go into the bathroom and just get familiar with the environment. I then modeled how to do the transfer. So I educated her on where her hands would go and how she would sequence herself to kind of build that confidence up. And then I finally got her to a place where she would transfer from the wheelchair to the toilet. And after that, after we had done so much small exposures, her anxiety had started to fade to the point that she was ready to practice walking into the bathroom. And so you can see how by grading these exposures allowed her to gain confidence. It provided that just right challenge. And ultimately, it helped her relinquish that anxiety so that she can engage in the task at hand, which is to transfer onto the toilet. Another thing that I did was I started to incorporate her preferred leisure tasks. So we talked about how much she loved crafting. Another thing about Cindy was that she was very spiritual. She was heavily involved in her church. She always talked about, reading the Bible and her relationship with God. And so I liked to combine those. So I had her do a lot of crafts in standing because she was very fearful of standing for a long period of time. But I had her do that and incorporate her spiritual practice within that. So I think we made a scripture jar. So she would write different scripture verses down in her jar that she could use, especially if she was feeling anxious or overwhelmed. We also did a ton of coloring, so coloring Bible passages or encouraging words, and it really helped her get over that anxiety where she was able to stand for a lot longer. As we talked about, I talked a lot about psychoeducation with her, following up, just discussing how she was going to continue to manage her anxiety and her psychosocial well-being when she was home. I also referred her to our meditation program. We're really lucky we have a CODA on staff that specializes in meditation. So he's able to go in and provide meditation practices. And that was also something that she found really meaningful and helpful for her in her mental health recovery. So you can see that by combining all of these different interventions, I was really able to help facilitate Cindy to gain that independence to go home, which is the ultimate goal. And also just promote her quality of life, that she would go home and she wasn't so fear of falling that she would stop engaging in all these tasks that she loves, like crafting. And a big one was being able to spend time with her grandchildren. So as you can see, addressing mental health is very, very important. Okay, wonderful. So now that was the completion of the lecture portion of this core curriculum. I look forward to meeting with you all next week. I'm anticipating that we're going to have a great discussion on how you all address mental health in your own unique practice settings. I included these reflection questions here for you to ponder this week, as we'll probably address many of these next week. And also, please be prepared to discuss past or current cases in relation to this topic. Also, please feel free to contact me if you have any questions. And I look forward to meeting you all soon. And I hope you have a wonderful Valentine's Day. Thank you.